Yeah,
Good evening, dear colleagues, young intensivist students. Today's session is on prone ventilation, a very, very important topic and something which has evolved to all ICUs now. Almost all patients of ARDS get prone if required, and very good results. So the speaker today is Dr. Balim Kumar Vaidya. He's a professor of anesthesia, pain and critical care, All India Institute of Medical Sciences, New Delhi. He's also the co-editor of the Washington Manual for Critical Care for the Southeast Asian edition. So I'll hand it over to you, Dr. Dalim, sir. Please start the proceedings.
yes, thank you, Dr. Tapesh, for the kind introduction. So today's topic is prone ventilation. So in next about half an hour or so, we'll be discussing the various aspects of prone ventilation in ICU. So the outline of the talk should be initially the physiological rationale of prone position, followed by what all evidences we have from the clinical medicine, and at the end the practical aspects of how to perform these prone sessions from the ICU. So first the physiological rationale of prone position. So you know what happens in supine position is that majority of the ventilation is directed towards the anterior part of the lung zone, whereas the posterior part gets most of the perfusion. However, in the normal lung, this will not have significant effect in VQ mismatching, but in a diseased lung where posterior lung zones are predominantly affected by disease pathology, then there will be a lot of shunting in the posterior lung zones and dead space in the anterior lung zones, which is classical in ARDS. So what happens when you prone the patient is that the posterior lung zones are now non-dependent. So the dorsal alveoli will get more and more recruited. They will open up, and the ventilation perfusion matching will become better, and ultimately leading to improvement in the oxygenation. So before we discuss in detail about the prone ventilation, let us understand about an important concept, which is heterogeneity, which is a hallmark in ARDS. So heterogeneity basically reflects the heterogeneous character of lung parenchyma in a patient who is affected with ARDS. So what happens in ARDS, predominantly the posterior lung zones which are involved will be non-aerated, whereas major part of the ventilation will be directed towards the anterior lung zone alveoli, which will be almost fully aerated, and the mid zones will be partially aerated. Some alveoli will be collapsed, some alveoli will be not. So how does this anatomical distribution of the disease pathology will affect the mechanical ventilation? So what happens in certain parts, for example, which are well aerated, the alveoli will be well ventilated both in inspiration and expiration, to the extent that even some of the alveoli will be at the risk of overdistension. Whereas when you have a consider an alveoli which is collapsed, mainly in a dorsal lung zone, that alveoli will not get ventilated in the inspiration, whereas a relatively normal alveoli which will take the all tidal ventilation, ultimately which was supposed to be going to both the alveoli equally, the healthy alveoli will take that part of the ventilation and will become over-distended. So thereby the dorsal lung alveoli will contribute to hypoxia because it will not get ventilated at all and the blood will be shunted, whereas the anterior alveoli which is well aerated will be at risk of overdistension injury. So if we look at the various parts of the lung tissue in this model of heterogeneity, consider this is the dorsal alveoli which is completely collapsed and non-aerated. That will not be, during the part of tidal ventilation, both inspiratory phase and the expiratory phase, that those alveoli are not going to get aerated at all. Whereas the ventral alveoli, which are already well expanded, will be at risk of overdistension and thereby various hollow trauma and barotrauma in the inspiratory phase of the respiratory cycle. Whereas the mid-zone alveoli, which are partially aerated, will have significant volume change during inspiration and expiration, and thereby will be at risk of athlete trauma. So, in a model of heterogeneous lung tissue, the dorsal lung zone will contribute to hypoxia. The ventral lung zones will be at risk of volutrauma, barotrauma, and overdistension, whereas the mid zone will be at the risk of significant stress, strain, and athlete trauma. Now, how does prone position will physiologically help this condition? So it will improve oxygenation, but how? Now there will be reduction of dorsal alveolar collapse. Now once the dorsal lung zone has move on to, these are the CT pictures and these are physiological representations. So when in the supine position, dorsal lung zone, which has now become more anterior, will be opened up. So those alveoli will open up and get recruited and receive significant part of the ventilation. Moreover, there will be improving drainage of secretions from the dorsal lung zones, the non-dependent lung zones. Second factor is that this opening up of new set of alveoli which were previously collapsed will improve the regional VQ matching or regional compliance, which will eventually improve the complete static lung compliance. Third important factor is the weight of the mediastinum. In the supine position, the weight of the mediastinum will compress significant part of the lung tissue like a sponge, whereas this mediastinum weight will now be off from the lung tissues, and very minor part of the lung tissues will be below the mediastinum right now in the prone position. So therefore, if you see the physiological models, the non-dependent lung zones in supine position is merely around 40%, which becomes nearly 55 to 60% in the prone position. So therefore, there will be significant improvement in the VQ matching, improvement of hypoxia, as well as improvement in the drainage of secretions. So these will finally not only lead to improving the oxygenation, this will also lead to improvement in the lung dynamics, pulmonary dynamics and mechanics. So that will allow you to ventilate the patient with lower tidal volume and lower pressures in the prone position than the patient was getting in the supine position. So now, whether all patients will have the similar benefit? No. The literature has suggested that there will be certain categories of ARDS patients who are benefited maximally from prone position. That does not mean that we'll prone the only this category of patients. We can prone any patient who satisfies the criteria for proning. But this is a set of patients who have shown maximal benefit from proning. For example, extrapulmonary causes of ARDS, patients with increased intra-abdominal pressure, or where posterior lung zones are predominantly affected with dependent alveolar collapse in the radiological picture. So these are the subset of patients who are likely to benefit maximum from prone ventilation. Now, how to select patients? So the patient selection will be based on the patient's oxygenation status. So patients who are moderate to severe ARDS, we know that moderate ARDS is PF ratio of 100 to 200 and severe is below 100. So it has been found that PF ratio less than 150 at a FiO2 of more than 0.6 and PEEP of 5 or more are better candidates for prone ventilation. So this is the subset of population who will be defined as refractory hypoxemia and candidate for prone ventilation. So once you have selected these candidates, when we should prone and how long we should prone. So the prone ventilation should be initiated early in the disease process. So it has been found that if the proning session is started within 36 to 48 hours of ARDS, then the patients will have maximum benefit. And you need to prone at least 12 to 18 hours per day. And you may require sessions for few more sessions, for example, few more days, depending on the patient's improvement. Now, before you prone the patient, once you've identified the patients for proning, we need to rule out contraindications. There are few important contraindications for prone positioning. The most important is spinal instability, severe hemodynamic instability, patients with open thorax or open abdomen, patients who are on VECMO with central circulation. So these are the categories of patients whom you can consider as contraindications. However, minor hemodynamic instability should not be considered a contraindication. Patients who are able to maintain mean arterial pressure more than 65 on minimal to moderate dose of vasopressor can be proned, because it has been found that doing proning per se will not worsen hemodynamics. There are various relative contraindications also which you need to check, and depending on the patient's risk benefit ratios, you need to decide whether to go ahead with the prone position or not if these criteria are present. Now, what are the main problems or disadvantages of prone position? Now, the most important problem is pressure ulcers. So, pressure injuries and ulcers are common in prone position, and that has to be taken care of while you are doing the prone position. Other important problems are dislodgement of tubes, catheters. There have been many reports of accidental extubations, central line catheters, and arterial lines coming out while proning the patients. Facial edema is a risk. Brachial plexus injury is a real risk if the arms are not taken care of properly. Other nerve injuries is also a possibility. Another important aspect of prone positioning is that CPR, point of care ultrasound, and various other interventions may not be possible in prone position, or may be difficult, and we do not have major data on this. So these will remain a important concern. Even after proning, you must realize that there will be a subset of patients who may not respond to prone position at all, and there may not be any improvement in oxygenation. And it has been found that as many as 20% of patients may not improve by doing prone positioning. So you should identify those subsets early. Now, what are the evidence in favor of proning from the clinical medicine? The most important article was this PROSEVA trial. This PROSEVA trial was published in NEJM in 2013 and in severe ARDS patients, and subsequently, this has significant role in popularizing the prone ventilation. So let us found a little bit more about the PROSEVA trial. In this randomized control trial, 466 patients were recruited based on the inclusion criteria of PF ratio of less than 150, FiO2 of more at FiO2 of more than 0.6, and PEEP of more than 5 who were being ventilated with the lung proactive ventilation strategy. And they were randomized into two groups: 239 patients in the prone ventilation group and 229 in the supine group, where the prone ventilation was given for at least 16 hours per day. So this had showed significant improvement in the oxygenation on lung mechanics, but most importantly, this has shown significant improvement in the survival as well. In this trial, the 28-day mortality was only 16% in the prone group compared to 32% in the supine group, whereas 90-day mortality was 23% and 41% in the prone and supine group respectively, which is evident from the Kaplan-Meier survival analysis CAR. Sorry. So, such significant and tremendous improvement in the survival rate subsequently encouraged the clinicians to adopt this strategy more frequently. And largest adoption of prone ventilation into our clinical practice were found during the recent pandemic of COVID-19, where so many patients were put on prone ventilations, and subsequently a lot of papers were published on the efficacy of prone ventilation in COVID-19. So, in COVID-19, not only the prone ventilation in mechanically ventilated patients, but also awake patients were used for prone ventilation, where they were encouraged to remain on prone while on oxygen by face mask or high flow nasal oxygen. Even patients on mild ARDS category on face mask and HFNO were asked to do awake prone and or conscious prone, and we reap the benefit of that. So we'll just show you our data on the prone ventilation in mechanically ventilated COVID-19 patients. And I just need to highlight here the importance of what I was saying before, the identification of prone responders. So in this small observational trial where we recruited around 50 patients with PF ratio at baseline of 61, who are already on ventilation with FiO2 of more than 0.6 and PEEP of on an average 12. So we found that 77% were prone responder. We defined responder by increasing the PO2 by at least 20 millimeter of mercury or by 20% from the baseline PF ratios. And we defined sustained responders by uh, maintenance of this benefit in PaO2 uh, after turning the patient supine. So we found 77% were responders and 73% were sustained responder. Now we identified which group of the population will be responders, and we found that it all depends on the lung mechanics predominantly and does not depend on the presentation oxygenation status or other status. So patients with lower driving pressure or relatively more static compliance of more than 11 were more likely to be having sustained response to prone position ventilation. The concept of extended prone position was also popularized during the COVID-19 pandemic, although it was there from before, but due to overwhelming of the ICU, many patients were not getting prone to supine or supine to prone in proper time because the staff are overburdened. So that's why extended prone sessions were tried, and there have been literature which shows that it was beneficial in majority of the patients, particularly from the COVID-19 ARDS pandemic studies. So in extended prone positions, the patients are prone usually for more than 24 hours, or even some studies have defined as more than 48 hours. And the physiological benefit which we have discussed on prone position are maintained on extended prone sessions as well. However, the most important problem we need to consider is the higher risk of pressure injuries. The incidence of pressure ulcers and injuries become much higher whenever extended prone sessions are being done. So, the one of the example I quoted this literature from a multicentric observational trial, retrospective trial from Chile, where patients were from 15 ICUs were put on extended prone sessions for more than 48 hours. And subsequently, during analysis, they were divided as per their response and duration of prone therapies into group A, B, and C. In group A, 2 to 3 days of prone session was required till the time patient reaches a PF ratio of more than 200. Whereas in group B, they required 4 to 5 days of prone session, and group C, more than 5 days of prone sessions were required. Now, if you see that the improvement in the oxygenation PF ratios in these different groups, group A, group B, and group C, all of them have showed a significant improvement by day 1 or day 2 in their PF ratios. Now, group A, which were ultimately required proning only for 2 to 3 days, had maximum improvement, whereas group C, which required more than 5 days of prone sessions to have maximal benefit, had a much slower improvement. And this was understandably because probably the patients in the group C were much more sicker and have more severe degree of ARDS. So that may be the one of the reasons. But we need to interpret from this study whether the pressure injuries and the risks were increased significantly when you do extended prone session or not. So from that, we can have a significant idea how long we can do the extended prone sessions. So it was found that the incidence of pressure sores were around 14% in group A, where 2 to 3 days of prone were given, whereas it increased so significantly to almost 45% when they are prone for more than 5 days. A steady increase in the incidence of pressure sores were found in across these groups. So this says that if we continue to prone beyond 2 to 3 days, significant number of people will be having pressure sores, which may be subsequently having a lot of other complications for the patients. So we should exercise extreme vigilance when you are using the extended prone sessions. So now let us talk about certain basic protocols. How you should you know use this background knowledge and our evidences in favor of prone into our practice in our ICUs. So while you are attempting to do prone sessions, first of all, your staff should be already adequately trained. Now, how do we approach it? First, we confirm the indications and rule out the contraindications. Then we need to designate the staff members. There should be at least 5 staff members when doing prone positioning. And these staff may be resident doctors, maybe nurses, physiotherapists, technicians from the various categories who have been trained. So you should first secure the endotracheal tube properly. Patient should be pre-oxygenated 100% before doing the prone position. Oropharynx should be suctioned properly, and pre-proning ABG can be done and documented so that we demonstrate the improvement later on. Now, although we use 100% oxygen before proning, you may use it, but it is important to realize that no disconnection should be done during proning the patient from the ventilator, because that will lead to a lot of loss of your recruitment and PEEP, which you have already set. So, this is just a safety precautions for the staff, and we should not document ABG after converting the patient on 100% oxygen. Then other checklist has to be ticked, like you ensure that all lines and catheters are secure and stable. You document the length at which different lines and catheters are fixed at the level of the skin. You need to take care of the Foley's, the intercostal drainage, particularly the lines and catheters which hang beside the bed. So those should be taken care of properly. They should be rolled into and put on the patient's bed along the side of the patient. And you also should make sure that patient's mouth care, skin care, daily hygiene protocol has been already performed, because for next 18 hours or so, patient you are not able to perform that. The eyes should, should be extreme care should be given to the eyes. They should be clean, lubricated, taped, and padded. And sedation and muscle relaxation extra bolus should be given. Now, needless to say, the patient should be on sedation as well as muscle relaxant infusion when you are proning the patient. But here I am talking about extra added bolus before turning the patient prone may be required. Now, what are the steps? Now, the steps will be like 5 staff will be required, at least 2 on the each side, and 1 will be on the head end. Staff members should identify themselves and perform this pre-proning checklist as I just discussed. Subsequently, make the patient completely flat. The ECG leads has to be removed from the anterior chest, and arms should be along the body and tucked in. Then you can place the pillows over the patient's chest and the pelvis, and cover the patient with the bed sheet on both the sides. Subsequently, you tuck in the bed sheets, roll in them properly, and horizontally move the patient to the opposite side, from where you will be putting the patient to the prone positioning. Subsequently, you do the lateral turn, and during this lateral turn, the persons on whom the patient is going to fall should place their hands accordingly so that they are able to receive the patient. And subsequently, patients will be prone. So when you put the patient prone, notice the position of the pillows below the chest and below the pelvis. The arm should be elbows, and the shoulder should be around 80 to 90 degree flexed, not more than that. The head should be turned to one side. All the pressure points should be padded and taken care of. Lines, catheters should be checked again. And some 15 to 30 degree of reverse Trendelenburg positioning should also be given to the bed. Now here, an important consideration is the use of pillows. The pillows use may or may not be performed, and it has got certain drawbacks also. Many times use of pillows, particularly these pelvic pillows, can provide undue compression over the abdomen. So in many centers, people avoid using the pillows altogether. Like in our centers also, we do not use pillows routinely. So if you are using pillows for proper patient positioning, be very careful that abdomen is completely free and you are not unduly increasing the pressure over the abdomen. Now, in prone position, certain important considerations are there. One of them is whether we can perform CPR in prone position or not. So The literature is evidences is limited here. However, limited case series which are available show that CPR can be performed in prone position and there can be success. So the hand position in supine patients are lower half of the sternum, whereas in prone position it will be on the thoracic vertebra at the level of the inferior angle of the scapula. The alternate approach has also been given that one person should place a hand below the patient's chest so that during chest compression there is adequate compression of the heart. However, no trial is there and still the evidence is limited. So if possible, patients should be supined as early as possible when you need to do CPR. If not possible immediately, we should not waste time and continue the CPR in the prone position. Regarding defibrillation or electrical shock delivery, the paddle placements should be right scapular and left axillary region. Normally in supine patients, the pad positions are right infraclavicular and left axillary, whereas in prone, it can be left axillary will remain the same, and instead of right infraclavicular, we put in right scapular region. Whereas another alternate positioning can also be done, like the biaxillary position, where you place both the pads in the axillary, infraaxillary region. Various prone preformed systems are there, like rotoprone therapy, striker frames, and all. In certain centers where proning is done on a large scale and regularly, this is used. However, there is no literature to show that this will be better in prone positioning compared to the conventional practice what we do in our ICU. There has been no significant data to show that pressure source are reduced or the efficacy of prone becomes better by the use of these frames. So you can continue to do proning as per our protocols in the ICU. So the last part, once you've initiated the prone position, you have trained staff in place and started doing proning regularly. What should we do further to do quality improvement? Now you can develop certain checklist and bundle of care for prone positioning to improve qualities. Now this is just one of the things I'm saying. You may have different other quality improvement initiatives depending on your setup. This is I'm showing what we had done during the COVID-19 pandemic in our ICUs. So we had a prone team since the staff was overworked and overburdened, and at a time we had around 15-20 patients who were in prone position, mechanical ventilation on sedation and muscle paralysis in ICU. We had formed a separate prone team who will go in and do the proning of these patients in the ICUs. So we had team members who were already trained and they are from different clinical specialty resident doctors like anesthesiology, surgery, medicine. We had nursing staff, technical staff, physiotherapists, and all the staff we have been doing continuous teaching program based on video and simulation based training to expand our team base. Now, for the AVIC prone, the protocol was very simple. Patient has to be alert mentally, and patient is able to communicate properly, eating orally. Patient is able to turn supine on his or her own anytime and hemodynamically stable, and there is no urgent need for intubation. So those patients are asked to remain awake prone for 2 hours at least, and then turn supine and rest for in half an hour in supine position, followed by again prone or lateral. And we used to document the improvement in the oxygenation by SpO2 before and after 2 hours of prone session. For prone ventilation in sedated paralyzed patient, the indications or contraindications were same. Checklist was also same as I just told you. But certain things we enforced, for example, any necessary procedure or intervention, if at all is to be done in a patient, you need to discuss it out and perform the procedure and document in the file before doing the prone session, because it may otherwise happen that you satisfy the criteria of prone, check out the contraindications and prone the patient, then you remember that, well, some procedures had to be done. So this is not right. So echocardiography, point of care ultrasound, any insertion of lines and catheters, everything has to be checked, discussed, performed, and documented, and then you prone the patient. Similarly, we had an extensive checklist like lubrication of eyes, cotton pad over the eyes, and one important aspect was that by patient secretions and the endotracheal tube fixations and other lines could get soiled and they might come out. So you need to have transparent dressing like tegaderms fixed over the ET fixation and other fixation devices, and you can use a absorbent material below the face so that secretions are taken care of. We used to use diaper below the face to absorb the secretions. And for the pressure points, you need to have appropriate pressure paddings. If you do not have the pressure paddings available in your ICU regularly, then you can use water-filled gloves. And as I said, no ventilator disconnection while making the prone. And to further improve safety and quality, you can use a signboard, prone signboard at the bedside, which will display the number of prone session, whether like it is second prone session or third prone session, what is the prone onset time, what is the anticipated time when you are planning to make the patient supine, that should be written, and what are the time you have planned to perform ABGs in this patient. So all these things should be documented so that and displayed so that everyone knows and your team members will perform the work accordingly. So to summarize, so we should use prone ventilation in our ICU. There is no doubt about it. So moderate to severe ARDS patients, particularly with PF ratio of less than 150, who are already on FiO2 of more than 0.6 or PEEP of more than 0.5, and still PF ratio less than 150, on sedation, on muscle paralysis, you should prone them. Initiate proning as early as possible during the disease course, preferably within 36 to 48 hours. Prone them for at least 16 to 18 hours per day. Identify the prone non-responders quickly so that you can decide on other modes of therapy like ECMO in those patients. It has found to improve oxygenation, improve lung mechanics, and most importantly, improve survival. But it is not without any disadvantages. There is significant incidence of pressure injuries, pressure sores, and dislodgement of lines and catheters. So the ICU staff should be properly trained, and there should be ongoing training program, at least video training program, and preferably simulation based training program in those patients. And it's better if you develop your own checklist and SOPs of prone ventilation so that it is practiced more often and becomes a standard of care. Thank you.
Thank you, Professor Vaidya. Can you stop the share screen?
Yes.
Very nice summary, and especially telling how to actually do it for the practical aspects. So just add to what you said, oxygenation improves in most of the patients when we prone, but the other thing is that the ventilator-induced lung injury also reduces.
Yes.
The more homogeneous distribution of ventilation, shear stress decreases. And in the Prozivir trial, and after that, subsequently, literature states that more benefit actually in terms of mortality is gained from reduction in villi rather than oxygenation.
Absolutely.
That
Absolutely.
is very important to realize. And even if the oxygenation is not improving, one should continue ventilation as so long as the PF does not decrease by 10. So one of the criteria, actually
Yes.
important criteria for stopping prone ventilation is the PF falls by 10 at any point. Apart from the
Yes. Yes.
hemodynamic, whatever, no, those things are separate. But as far
Yes. Yes. Right. Absolutely right. Fully agree.
yeah, then one more thing is, there's a misconception that when we turn the patient, the blood flow will increase to the sternal area. Initially, patient, the blood flow is when the patient is supine, the blood flow, like you said, is in the dorsal area, right? And when
Yes.
the patient, this was actually thought earlier, also, and think that the blood flow increases in the ventral area, the sternal area when you prone. But the blood flow still remains more in the dorsal area. But the oxygenation improves more in the dorsal area, and the overall V by Q mismatch improves.
Yes, yes,
Very
yes.
important concept. Initially, literature said this only, that the blood flow also changes. The blood flow improves in
Mm.
the sternal area upon proning. But subsequent studies then have shown,
Yeah.
now it's clear that the blood flow still remains more in the in the dorsal area. So that is very important to realize. Then coming to the fact that when you prone the patient, the chest wall compliance of the lung overall increases. That's very important. And only if the compliance of the parenchymal lung, the lung parenchyma improves, will there be an overall benefit.
Mm.
That is why 20%, like sir showed, 20% of the patients do not respond. Because here,
Yes.
chest wall compliance increase is more than the improvement in the lung compliance.
Mm.
Another very important factor to realize.
Yes.
And now coming to the fact that hemodynamics. Hemodynamics is very important. Dr. Bedia showed you that moderate doses or more of vasopressin is a contraindication to proning the patient. And this was seen in the Prosiva trial also, where patients who were hemodynamically unstable had a higher modality.
Mm.
A very important thing is what happens to the blood pressure or the cardiac output when you prone the patient. So in most of the patients, the cardiac output actually improves. 80,
Yes.
80% of the patients have an improvement in the cardiac output. That happens because of one or two reasons. One, when you turn the patient, the abdomen actually, the pressure goes up a little. So there's a
Mm.
squeezing of the unstretched volume. The venous return increases. Second is your compliance improves, the oxygenation improves, the acidosis decreases, and there's a decreased compression on the capillaries in the lungs. The pulmonary vascular resistance decreases. The venous return increases, and the pulmonary vascular resistance decreases. The right ventricular output improves. Subsequently, the cardiac output improves. 80% of the patients are like this.
Yes. Right.
Patient is not preload dependent, or sometimes, he's grossly hypovolemic, the IVC gets compressed also when you turn the patient.
Mm. Mm. Mm.
Some patients, they say around 20% do not improve the cardiac output. And if you improve the cardiac output, mostly you will improve the blood pressure, but cardiac output improvement is not synonymous with improvement in blood pressure. So,
Absolutely.
because I think, what is your experience with the blood pressure, sir, in these patients?
Now, what you're saying is right. So previously, say 10 years before, we were very hesitant in proning patients whenever they are on any vasopressor. But nowadays, even on patients on say 10 mics or 15 mics of noradrenaline, we prone them because we know that proning is not going to have any compromise on the blood pressure. So cardiac output will improve, and subsequent overall patient's improvement, as you have just discussed, the volume status and all, will not have any significant impact on the hemodynamics. So therefore, we are more, we can say liberal on proning the patients even on when they are on vasopressors.
Yes, yes, absolutely. So we can expect an improvement actually.
Yes, yes, and it
Dynamics.
do happen in
Yeah,
many patients. We see that.
yeah. Only thing is when you are actually turning the patient, no, immediately post turning, you have to be very careful.
Yeah.
That time you may have to increase before that your vasopressin
Yes.
and bring them down.
Yes. So
That is
initial
very
we,
important.
yes, you're absolutely right. We increase, in fact, the noradrenaline or whatever the patient is on vasopressors. We increase and then turn the patient prone. Initial 5-10 minutes is very crucial, and then the hemodynamics will settle.
Yes, yes. So what about feeding? How you like to comment on the feeding of these patients?
Yes, we continue feeding. So just before proning, we cap the nasal NG tube, fix it properly, and then after turning the prone, we immediately resume. But during the first session, we initially start with a bit lower volume. Then it was in supine, and after few hours, if we see that there is no issues, then we go to the proper whatever the volume we had plans.
Right, sir. And one more thing is that there is no change in the readings of CVP. I mean, you can just like prone
Hmm.
position, you can see the CVP, you can see the PPV, so arterial drain,
Yes,
two things remain
yes,
same. That is another concept that should be realized by everybody.
yes,
So,
yes.
anything else
So
you want to add, sir?
no, no, I think you have also covered everything, the extra things which I missed actually. So that is also very important that almost all the hemodynamic monitoring we do remains good at the prone position as well. So you can continue to assess the patients and treat accordingly. The other aspect does not get compromised when you are proning the patient.
And the other thing you have very nicely pointed out that you can defibrillate these patients by placing the paddles in the position you have shown,
Yes.
axillary bilaterally. So,
Yes.
yeah, like you have told, there is no evidence, clear evidence on CPR in this position, but definitely defibrillation you can do successfully.
Yes. 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 Even
Okay,
there are
sir.
case series of more than 25 patients where successful CPR has been done in prone position
Right, sir.
with successfully. Yeah.
Great. So I think there are no questions, and if there
Yeah.
are no further comments, we'll close the session. Thank you so much, Dr. Baidyas. Thank you so much.
Thank you. Thank you.